So here we are with a crescendo of excitement palpable through the MSc universe. We have arrived at the end of chapter 3, which I lovingly call the chapter from hell. So notice that from here on in, all we have left, hallelujah, is the organisms that are extremely unusual bacteria. So often, this is what's going to dictate their pathogenesis. So understanding how these guys fit into this scheme is really important for predicting what your patient is going to look like. Now, if you notice, we're into the non-gram staining organisms for a variety of reasons. Mycobacterium, which we've already done, if you recall, doesn't gram stain because it has a very waxy cell coat. Mycoplasma, which we will do next, doesn't gram stain because it doesn't have a cell wall. And if you recall how the gram stain works, it is the thickness of the cell wall that retains the primary stain. Now, Mycoplasma and Mycobacterium, notice, are going to have a gram-positive anatomy. In other words, they don't have an outer membrane. So they are more closely allied to the gram-positive than they are to the gram-negative. But another way of considering these guys is to think about which ones of these are extra versus intracellular. So notice if I'm extracellular, I would anticipate that the immune response would be neutrophils being the innate response, followed by the cleanup by APC2, followed by stimulation of T helper 2s, followed by stimulation of B cells, and the ultimate production of antibody. But remember that since we're in an unusual group of organisms, you're going to find that in many cases, the immune response to these guys is unusual. And so that's why having them at the very end of the chapter, where you can sort of segregate them in your mind into a group that is different than what we've done before, is going to be very helpful to you. Now, of the ones of these who are extracellular, we have Mycoplasma, and then we have the spirochetes, including Treponema, Borrelia, and Leptospira. The remainder of the gram-negative morphology organisms, who you can remember have an outer membrane and therefore will have issues with endotoxin shock when we start to treat them, are the chlamydia, the rickettsia, and the spirochetes. And of those, notice, it is the spirochetes who are extracellular, and chlamydia and rickettsia are intracellular. But suffice it to say that the rule that I've tried to beat into your brain of extracellular being neutrophil M2TH2 and the intracellulars being APC1, TH1, and cytotoxic, those rules may be dislodged in this particular topic. So be aware of the fact, just to give you an idea, Mycoplasma, although extracellular, as you'll see, is going to be the most common atypical pneumonia of young adults. And yet, as an extracellular, I would anticipate that it would cause typical pneumonia. But remember, all of those FMET peptides and those other pyogenic PAMPs that other organisms in the bacterial chapter have on their surface, those are missing from Mycoplasma, and so the patient does not go down the normal pathway. All right, so let's start with Mycoplasma, even though you could argue that this is the most unusual of all the bacteria we'll talk about. It's non-gram staining, but anatomically gram-positive, has no cell wall, and is extracellular. So remember, we have Mycoplasma pneumoniae, which is the most common, as I said, atypical pneumonia of adolescents and young adults. Transmission, human to human via respiratory droplets. When I speak about an atypical pneumonia, remember, my presenting complaints from the patient are going to be a dry cough and fever and sore throat. Okay? This is going to have an indolent onset, partially because the immune response that you're going to mount is not going to be the appropriate one for some time. And you can think about this as reflecting in the term walking pneumonia. If I took an immediate response that resolved the infection, it would not last this long. So that should tell you that your immune response is sort of spinning its wheels when you are initially exposed to this. It's a very slow-growing organism, taking about 10 days in culture to produce unusually shaped colonies on agar. And remember, I have to give it sterols in its diet because it is the only one of the bacteria that has cholesterol in its membrane. It's often mentioned that these patients will develop cold agglutinins. It's not a perfect test, it's non-specific, but 65% of patients with mycoplasma will develop cold agglutinins, which are simply hemagglutinins that will agglutinate your own red blood cells at 4 degrees centigrade. So the test is simply performed by taking a sample of blood, putting it in an ice bath, watching it agglutinate, and then taking it out, warming it up, and watching it return to the liquid state. As I said, the microbe lacks the signaling for acute inflammation. So the body by default ends up making a Th1 response in an inappropriate fashion. The P1 protein of the organism mediates attachment. It stops your ciliary activity and causes desquamation of the epithelia. But at the level of histology, the infiltration of the area is going to be with a mixture of lymphocytes and plasma cells and macrophages eventually. Please remember, I'm not going to get anywhere treating with cell wall antibiotics, so erythromycin or tetracycline are used. Urea plasma is a member of the same group, and by its name, it should remind you that this is a urease-positive organism. So it is an organism that can be sexually transmitted from the human genital tract and then move up the urinary tract to cause cystitis. So generally, persons will present with dysuria, colicky flank pain. And so if the urinary tract infection does not respond to the standard therapy, then this one becomes the default thought. But remember, because it's urease positive, the urine will have an alkaline pH, and this will be nitrite negative. Nitrite was my assay to test for the Enterobacteriaceae. Now, as you can imagine, as I elevate the pH in the urine, I can anticipate seeing exactly the same type of stones formed as I could with Proteus. So struvite describes their chemical composition. Staghorn describes the fact that their points stick into the calyces, and so they look like the antlers of a deer. Again, treatment tetracycline, no cell wall antibiotics. As we enter the group of the spirochetes, notice that Treponema pallidum is quite unusual anymore, but still fairly heavily asked on your exam. The numbers, 12.1 cases per 100,000 population. It has been rising since 2010. The advent of HIV and the encouragement towards safe sex caused the rates to fall before that. But since more recent times, when many people are on PrEP for prevention of HIV, some people have relaxed their standards of safe sex. And also, unfortunately, it has been rising in nursing homes where persons have the misconception that just because they no longer are young enough to get pregnant, that safe sex is not an important thing. So it is a possibility, and they still will ask, transferred human to human via sexual or transplacental or transfusion, although that would be quite uncommon in the United States. Notice that the presentation of syphilis, which is the disease, is going to be in multiple stages. This is another organism that your body just doesn't know what to do with. So it begins as a painless genital ulcer within 10 days to 3 months after unprotected sex. It is indurated, so a hard and painless genital ulcer. And the best diagnostic at this stage is dark field microscopy of either a biopsy or scraping. That ends up being the favorite question, because make certain that you understand that for each of the stages of syphilis, this one being primary, we're coming next to secondary and then on to tertiary, for each of the stages, the diagnostic of choice would be slightly different. So I'm actually looking for the organism by dark field microscopy in primary syphilis. This, in untreated cases, may progress to the secondary stage, and during this stage, the patient will be covered with a generalized bronzing rash. So the tone of the skin will be darker than would be natural for that person. And in addition, condylomata lata are those flat wart-like protuberances that can be found on the perianal or axillary skin. Notice this is one of those rashes that involves the palms and soles, and it can also be associated with hair loss. Now, the VDRL is a non-specific serologic test that will generally turn positive during this stage. And you should know that we have two categories of serologic tests for syphilis. One that are said to be heterophile antibody tests. Heterophile, if you dissect the word, other loving. So basically these are cross-reacting antibodies. And what they react against is mammalian cardiolipin, which has nothing to do with the pathogenesis here. It simply ends up being a convenient diagnostic. So the non-specific tests are always cheap and easy to administer. The problem is that they are non-specific. So I always have to confirm with a specific test like the fluorescent treponemal antibody or the microhemagglutination for treponema pallidum. Okay, both of those are much more expensive and more difficult to obtain nationally because of the fact that they require a living source of treponema, and this organism is not easily grown. You notice I do not mention culturing it in any of these diagnostics. Now, if the person again is untreated beyond that 1 to 3 month point, 5 to 20 years later with unresolved infection, these persons will develop what we call gummas. And gummas are simply syphilitic granulomas. They are the end pathologic lesion when the immune response has tried everything in its arsenal and has not succeeded in removing the pathogen. So I will find these throughout the central nervous system and vasculature. Of course, from your neurology, you will remember what tabes dorsalis looks like. But remember, I can develop granulomas in the aorta as well, and death can be from the rupture of those materials. So at this point, only the specific serologic tests will work. The non-specific ones will generally become negative, and in cases of protracted syphilis and tabes dorsalis being present, it's often the PCR of the central nervous system that ends up being the diagnostic of choice. Now, what's going on here is a mixed bag. Clearly, the organism has endotoxin, so that's going to have endothelialitis and endarteritis as end causes. I'm going to develop granulomatous cuffs around all of the blood vessels and realize that even when I begin to drug treat and release all of that endotoxin that up until then was inside the living creatures, I can end up with the Jarisch-Herxheimer reaction. which is simply an endotoxin shock that happens within 24 hours of drug treatment. Now, you need to be aware of that possibility because, of course, it could otherwise look like your patient had a penicillin allergy, since it is penicillin that we use in order to treat virtually any stage of this that we have. Borrelia is our second spirochete. This is the most common tick-borne disease in the United States and the agent of Lyme disease. Realize I have 30,000 cases per year in the United States, and it has now gotten into all 50 states, although geographically the incidence will be highest in the Northeast, in the Great Lakes region, and in Washington state. So realize they're likely to mention probably northeast seaboard on the Atlantic coast. And remember that it will be summer months because of the tick needing to be outside. It uses dogs and mice and deer as reservoirs and is transmitted by a very small tick in the genus Ixodes. Now, as we go into other chapters, you'll remember in total, we actually have 3 things that are transmitted by this same tick. Borrelia is simply the first one we have come to. The next one we will come to is Anaplasma, which is an organism in the Rickettsiales coming up. And the final one in the parasite chapter is Babesia. So realize if my patient is having a particularly bad day, I could end up with 3 things from one tick bite. And I can assure you that that would complicate diagnosis when you've got 3 things going on at once, okay? Now, once again, the spirochetes are organisms that your body seems to have trouble with. So I have multiple phases of disease, and the key with Borrelia or Lyme disease is to try and make certain that you get rid of it as quickly as you can. So even though I have heretofore suggested that you always know what you're treating before you treat, I will simply say now that most persons with presumptive cases will be treated with a course of doxycycline or amoxicillin and will then be certain not to progress any further. Because as you'll notice, as I go down this chart, the problems in the patient become more and more serious. The initial presentation within the first month after the tick bite is one that's really protean. Fever, fatigue, myalgia, headache, joint pain. Well, this not only is something that would be described as being a flu-like illness, which covers unbelievable amounts of ground, but it also indicates to me that this is largely a stage that is cytokine-driven, because most of those things would relate to my body's response immunologically. The one thing that you can hang your hat on, if it occurs, is a target-shaped or bullseye rash. That will start at the point of tick inoculation and spread outward from that point. The problem, unfortunately, is that if you are bitten in between your scapula or in another place where you're not looking every day, you can miss this stage, and then it becomes a problem because it continues to progress. They're likely to mention summer months. They're likely to mention geographic clues. And so your diagnosis is usually an enzyme immunoassay followed by a Western blot. Even in cases where I get negative results on these, most physicians that live in the endemic area will treat and simply say it's better to prevent than it is to try to cure. What happens as time goes on, 2 to 3 months beyond this, is that I will see things like facial muscle paralysis. Bell's palsy is very, very common. And 3 months to years later, I'll develop disorders of sleep and memory, decreased concentration, joint pain, And the arthritis in those cases is believed to be autoimmune. But the point is, as you see, if you do not get rid of the pathogen early on, I get continuous inflammation from the organism. It has lacking of classic endotoxin, but still seems to irritate the endothelium. The outer surface proteins of the organism inhibit complement fixation. And over time, I simply get more and more of an immune response against it that ends up doing the majority of the damage. Our final spirochete is Leptospira. This one is a zoonotic existing in humid areas of the globe. In our region, Hawaii is the state of highest incidence, so it's often mentioned. And remember that the reservoirs of this are either rodents or dogs or cattle. So the transmission to humans is through water that has been contaminated with their urine. It gets into the body through breaks in the skin or mucosa and causes a severe disease the whole way up to shutting down and causing kidney failure. But starting out with fever and nausea, vomiting, headache, abdominal and muscle pain, which again covers a tremendous amount of ground, would fit into the flu-like illness and would classify as probably being cytokine driven. I would suggest that they almost have to suggest either an occupational or recreational exposure to water because our diagnostic is serologic. And as always, if it is a serologic diagnosis, then they have to tell you which antibodies were found, which gives away the diagnosis. Now, the name Leptospira interrogans should remind you that this is shaped like a question mark. To interrogate someone is to question them, right? So the organism has hooks on its ends that it apparently uses to go through the tissues. And of course, it is endotoxin containing, so the action on the endothelium is contributory to the ultimate kidney failure when we see wild disease, the end pathologic disease. Treat with penicillin, doxycycline, ceftriaxone. Next, we have the Chlamydiaceae. Now, again, I don't stress these taxonomic technical terms, but you know that that's a family because of that suffix. These guys are not gram staining because they are obligately intracellular. And they're obligately intracellular because they don't make enough ATP, they don't make ATP, and their cell wall lacks muramic acid. Now, you will find some texts that will talk about a peptidoglycan that lacks muramic acid. I would argue that's sort of an oxymoron, since there are only two constituents to peptidoglycan, and they are muramic acid and N-acetylglucosamine. So if I take out the muramic acid, it's certainly sufficient to say that this is an unusual cell wall. Now, inside epithelial cells, they exist as so-called reticulate bodies, which can be seen inside the cells on a section. The transmission form, which is extracellular, is the elementary body. So think of the R in reticulate, implying that this is the reproductive form inside the cell. And think of the elementary body being out in the elements. Okay? Now, transmission, contact, sexual, intrapartum to neonatalize. Remember, this is our third agent of ophthalmia neonatorum. Chlamydia trachomatis D through K are the serotypes that are the most common bacterial STI in the United States. And the memory tool here, which is not very ladylike, so plug your ears if you're going to be easily offended. But if you think of something that is often involved in the transmission of sexual diseases, then that reminds you those same serotypes, okay? And a hint, it's not a duck, okay? Chlamydia trachomatis, the other serovars, these are the ones that are the #1 cause of infectious preventable blindness, and these are A and B and C serotypes. There you go. In the sexual transmitted disease, it frequently will manifest as dysuria in the male, and the female is often asymptomatic. Remember, this is an obligate intracellular, so I'm not going to call in neutrophils, and if I don't call in neutrophils, I don't get that painful inflammation. So I'm going to scrape the affected area and find those intracytoplasmic inclusions. I cannot grow on agar, but I can use tissue culture. And remember, on a pelvic exam, this will typically develop the chandelier sign in the female. Granulomatous inflammation is what causes the ultimate fibrosis and scarring. So this is a classic pathway. This would be the APC1, TH1, cytotoxic cell called in to kill the infected cells. But remember that fibrosis and scarring are the end solutions to this problem of having any intracellular pathogen or other causing damage. So scarring in the fallopian tubes is what ends up causing the infertility that we see associated with this. Early on, there's interleukin-8 released from infected cells, so I will see a very early neutrophilic infiltrate, but it does not persist. And remember that this can be transmitted to neonates by passage through the birth canal. And it is a more protracted ophthalmia than the others that we spoke about. This one requiring a course of therapy after birth for about 10 days. The infection of the eye of the adult, trachoma, as I said, different serotypes. And what happens is that the granulomatous inflammation around the eye causes the swelling, which causes the eyelashes to turn inward on the sclera, and blinking causes the scratching, which ultimately leads to the scarring. In the case of serotypes L1, 2, and 3, these are the agents of lymphogranuloma venereum. And if you'll notice, this is a soft and painless genital lesion. Treponema was hard and painless. This one is soft and painless. But lymphogranuloma, venereum, you'll notice that this is not going to be in the United States. Okay. And it involves suppurative involvement of the inguinal lymph nodes, which may ultimately be painful, but the lesion on the genitalia, the primary lesion, is generally painless. We have two other species, relatively minor, Chlamydophila psittaci and Chlamydophila pneumoniae. Those are distinguished into a separate genus because of the pigmentation granules that are there. But remember that really, as long as you know chlamyd is referring to this entire group of organisms, you've probably got what you need. Psittaci is the one that comes from birds. The species name refers to the psittacine birds, which are in the parrot family. It's an atypical pneumonia, which shouldn't surprise you. Chlamydophila pneumonia is the one that causes another type of atypical pneumonia and infects smooth muscle and endothelial cells in addition to epithelia, causing changes in the intima that may look quite similar to the early changes of atherosclerotic plaques. Treat with tetracyclines, doxycycline, etc. We use erythromycin in neonatal eyes, but remember, we do have to continue treating in the case of D through K, making it into neonatal eyes, we have to continuously treat for 10 days after birth in order to make certain we get rid of it. The Rickettsia, non-gram staining, obligately intracellular, the reason being they don't make enough ATP for independent existence, but they have normal peptidoglycan, okay? Make certain that you know these facts at the top of the page because they become instrumental in distinguishing between these unusual forms. Now, this one is a vector-borne family. We have Rocky Mountain spotted fever, which is the one that's common in the mountain regions, but not in the Rocky Mountains, okay? Realize it got its name because of the fact that the agent was originally isolated in the Rocky Mountain labs. And the Rocky Mountain labs, a little bit of history here that you don't need, but the Rocky Mountain labs became Montana State University, which is the other MSU. And so it's named Rocky Mountain spotted fever because of the sacrifice that the scientists made in order to establish the etiology of the pathogen. It was the first of the Rickettsia ever seen, and it was beneath the ability of microscopes of the day to see it. So at the final step, when they were trying to prove that what they had isolated was indeed the agent of the disease, 4 of the people in the department volunteered to be inoculated. They had no idea how much they were inoculating because, remember, they couldn't see it with a microscope, and 3 out of the 4 of them died. So I tell you that story not because I'm from Montana and my microbiology department has a mural of that in the front lobby, but to point out to you that you need to be aware that they're much more likely to give you a case of Rocky Mountain spotted fever in Oklahoma or Tennessee, North or South Carolina. Those are not in the Rocky Mountains, okay? The other Rickettsia, many of them are involved with ectoparasites like lice and mites and so forth. Those really have been eradicated since the end of trench warfare. So now they would be associated with extreme poverty and crowding and poor sanitary habits. But I frankly think they're unlikely to ask them. I would certainly know Rickettsia rickettsii, the agent of Rocky Mountain spotted fever. And notice again, fever, headache, rash, and shock. That covers a lot of ground in the flu-like illness to begin with. So you're going to have other clues because we actually diagnose it serologically. But the rash is maculopapular to petechial. It's going to begin on the ankles and wrists, and then it will spread toward the midline. This is a centripetal movement of the rash from the wrists toward the midline. The palms and soles are involved. This is my last one in this chapter for that to be true. The only other one I will come to in the viruses is Coxsackie. The patient may also have an absolute laundry list of other symptoms. GI, periorbital swelling, signs of meningitis and arthralgia. It truly could be almost anything. So you're going to depend on the history of tick bite, if at all possible, the endemic area, and then they may mention the Weil-Felix test, which is another heterophile antibody test that involves the agglutination of proteus organisms. Remember, heterophile means cross-reactive. The tick that transmits this is the same tick that transmits Francisella, the dermacenter tick. The other 2, Ehrlichia schiefensis and Anaplasma phagocytophilum. If you'll notice, Ehrlichia and Anaplasma are both going to make fruit-like clusters or clusters of berries inside white blood cells. So for monocytes with Ehrlichia and neutrophils with Anaplasma. Remember, I said at one point there's nothing that lives inside a neutrophil. Well, this one lives in the cytoplasm of the neutrophil. It's not in the phagolysosome, and it must have an awfully rapid reproductive rate because neutrophils have such a short lifespan. But regardless, I did lie to you very briefly before, and I try not to do that too much. Okay? Now, the tick that transmits anaplasma is the same one that transmits Lyme disease. So I spoke about that before as being one of 3 agents that I can get from a single tick bite. The symptoms, totally protean, okay? There's no rash. It's going to be very difficult to distinguish these from anything else unless they were to mention the tick or unless they were to mention what they found inside the white blood cells. But if you notice, all of these have in common that they really look like an endothelialitis. They are a cytokine storm-driven problem in endothelial cells. Maybe not living there in the case of Anaplasma and Ehrlichia, but certainly causing modification of the endothelia and the response of those cells to respond to cytokines. Treatment, doxycycline. Remember, Rocky Mountain spotted fever is a fatal illness, so I need to begin therapy if I have any suspicion, even without confirmation. So that brings us to the end of this most painful chapter. Make certain before you go that you are able to look through these items and verbally explain them to yourself in your own words. There's a lot of material here, but not all facts are created equal. So focus on diagnosis and therapy and mechanism of pathogenesis, and you will have everything you need to do well on this section of your exam.